Hi, I'm Diana Tordoff from the University of Washington's Department of Epidemiology. I'm excited to introduce a new article I wrote along with Drs. Michelle Andrasik and Dr. Anjum Hajat about the misclassification of sex assigned at birth and the BRFIS and its implications for transgender reproductive health. In 2014, the BRFIS began offering a module to capture transgender and gender nonconforming identities. And although the BRFIS provides much needed data on these populations, these respondents are vulnerable to misclassification of sex assigned at birth. In this paper, we applied quantitative bias analysis to explore the magnitude and direction of systematic bias present as a result of this misclassification. The BRFIS ascertains sex assigned at birth based off of the sound of the participant's voice and through questions that conflate sex and gender. As a result, the BRFIS misclassifies sex assigned at birth in 30% of individuals who self-identify as transgender. The BRFIS also uses skip patterns based on sex. That is, only people classified as female are asked about Pap testing, hysterectomy, and pregnancy, and only people classified as male are asked about PSA testing. Thus, 30% of transgender respondents are excluded from questions relevant to their reproductive health. To determine the degree of bias present in measures of reproductive health among transgender respondents, we compared two multiple bias modeling approaches. We first used a selection bias model, since individuals are either included or excluded from the subsample asked reproductive health questions based off of how the BRFIS determines their sex. However, misclassification and the resulting skip patterns also result in missing data. Thus, our second modeling approach employs imputation methods. We found that transgender individuals excluded due to sex-based skip patterns are demographically distinct from those who are asked reproductive health questions, suggesting that there is noteworthy selection bias present in the data. We also found that most estimates were highly sensitive to bias. Before discussing implications, I want to highlight some limitations. First, we rely on sex assigned at birth as a proxy for reproductive anatomy. These assumptions do not account for intersex individuals or individuals who pursue gender-affirming procedures. In addition, due to the lack of external data to inform the degree of selection bias or confounding, we considered a wide range of bias scenarios. A final limitation is that no authors on this paper are transgender. Despite these limitations, we believe our results have important implications. A large degree of uncertainty is introduced by the BRFIS's methodology for ascertaining sex assigned at birth and its reliance on skip patterns based on sex. Thus, BRFIS data provide non-representative estimates of transgender reproductive health. Lastly, these findings highlight the importance of using validated sex and gender identity questions for health surveys, especially those that are nationally representative. Thank you, and we hope you enjoy the paper.